Good afternoon, and welcome to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative, Unraveling Emotional Dysregulation and Aggression, Updates on Medications and Behavioral Treatments, presented by Dr. Joseph Blader. My name is Kathy Dixon, and I'll be moderating the session today. I will cover a few housekeeping items, and then I will turn it over to Dr. Hannah Stevens, the Director of University of Iowa's Child and Adolescent Psychiatry Division. Following the presentation, we'll have time for questions, so please use the Q&A feature in the webinar toolbar to submit your questions, and we'll cover as many as time allows. The webinar will be recorded, and the link will be shared in the follow-up email. Instructions for how to claim continuing education credit will be uploaded to the chat section, and I will also send this information in the follow-up email after the session. So with that, I'll turn it over to Dr. Stevens.
Thank you so much, Coffee. You always do such a wonderful job, and people who have been to your webinars before will know that the only reason this happens as wonderfully as it does is because of Coffee's amazing work. So, but we all have another amazing person here to talk the rest of the hour to us about this very important topic for youth mental health. Joe Blader, we're so fortunate to have him here today. He is the Meadows Foundation and Semp Russ Professor in Child Psychiatry at the University of Texas at San Antonio. He, of course, have moved to this position after extensive training in the past, where he got his degrees from Tufts and Queen's University in Canada and the Children's Hospital of Eastern Ontario in Ottawa, as well as doing scientific and research training in epidemiology at Albert Einstein College of Medicine. He's previously held positions at Northwell Health System in New York and at the NYU Child Study Center, Stony Brook University School of Medicine, and Albert Einstein as well. And I actually became aware of his expertise in this area because of his publication of work in this area in many places. That has included work funded by the National Institutes of Health and by other private and government organizations, as well as being an editor for publications such as the now open access edition of the Journal of the American Academy of Child and Adolescent Psychiatry. So we get to hear about how he has come to this wonderful expertise and all the wise things he'll be able to tell us because of the time he's spent learning about young people who experience negative emotional reactivity that leads them to have social and behavioral problems, including aggression. And I just feel so lucky. So thank you, Dr. Blader, and we'll allow you to take it away.
All right. Well, thanks so much. It's such a great pleasure to be here. And thanks a million for the lovely introduction. I really appreciate it. So these are my disclosures. And what do we want to talk about today? I wanted to talk a bit with you about aggressive behavior among kids in its and what's the psychiatric context in which these difficulties arise, and say a little bit about what's the perennial issue here. Is aggression something that can pop up in all sorts of psychiatric contexts? And you really have to think about it distinctly for each kind of disorder that that might occur in, or is it, as I say, a transdiagnostic concern that we can, where it's more similar across its manifestations than it is different. And believe it or not, that has a significant impact on the regulatory framework that we've had, that medication treatment for these kids has been wrapped up in, and may have a little bit to do with our current state of affairs in terms of what we know and the large amount that we still don't know. And then finally, on to the fun part about management and treatment of these issues, and spend a fair bit of time on pharmacotherapy approaches, and I want to give you some orientation to the guiding principles of the psychosocial treatments for kids with behavioral disturbances that include aggressive behavior. For us in child and adolescent psychiatry, impulsive aggression and high irritability, overreacting to things, flipping out over small provocations. That's our strep throat. Well, except strep throat, gets better. Uh, uh, Sort of the chronic, or it's like our asthma, you might say, if we got to pick a chronic thing. This is what in child psych we do day in and day out, and I know that because we have a similar consultation program for pediatricians here in Texas. Um, I know very well that it's a common issue for y'all. And so this is not an atypical scenario. Um, Young man is, loses his temper, and when he loses it, he can become, as you see, quite destructive. So the family doesn't even bother fixing the walls because it's just um, a revolving door. And what does the family say? We always debate mids. How true. So, with that, why is aggressive conduct a psychiatric concern? Well, first of all, nearly all the childhood disorders, as we'll see, in which aggressive behavior occurs, themselves have a long uh, risk for long-term dysfunction, even if they didn't have aggression. What do I mean by that? Well, ADHD, that alone has carries a lot of risk. And when or kids on the spectrum, obviously, but when you add aggressive behavior to that, so that already kind of tenuous clinical picture, you add aggression to that, and it's a marker of greater severity and predicts heightened long-term risks and adverse outcomes. Aggressive behavior is the leading reason that pre-adolescents, at least, are psychiatrically hospitalized, and it's probably the second reason for adolescents, with, of course, depression and self-harm risk being number one. And as we'll talk about, it's also the leading reason that young people receive antipsychotic medications. They're getting, most certainly pre-adolescents who are getting antipsychotic treatment. It's not because they have psychosis. It's because the behavior is quite out of control, as well as all other sorts of polytherapy is highly associated with trying to deal medicinally with these types of difficulties. So let's define it a little bit. So what do we mean? Usually, what we're talking about is outbursts, lashing out, destructive behavior toward things, other people, oneself, verbally aggressive conduct, typically in the context of high negative emotionality, mood disorders, folks who have a lower threshold and limited tolerance for anger or frustration. So it's the behavioral discharge, so to speak, around those things. And not as numerically prevalent, but still, another scenario is where you could have folks who have distorted cognitive processes. That's also, a psychiatric condition that can predispose to aggressive behavior. So false alarms, as in, paranoia, or feeling impelled by some force. So, more common in adults, of course, but auditory hallucinations, or in the context of, say, bipolar disorder, beliefs about entitlement to impose my will. You just get frustrated because why aren't you listening to me? I have this great idea and you're thwarting me and all the wonderful things that I'm going to do for humanity. Um, so in addition to the negative emotionality we talked about, impulse control deficits, a la ADHD and other things, those are also highly associated. And there's a small group within that who well, let's put it this way. For the most part, we're talking about kids who are hot-headed, but there is a small, relatively small group who we would say are cold-hearted, lacking in empathy and would just as soon, hurt you to take your watch or whatever as say hello to you. Um, Fortunately, that's not all that prevalent, but you do see it often enough. And in fact, that's its whole separate area these days in child and adolescent psychopathology, what we call callous and unemotional traits. Um, but the fact is, most of those folks also have impulse control deficits. Kids who have high anxiety, usually, triggers for avoidance or escape. They're more likely to overestimate threat, so they're going to overreact to what they perceive as somebody intending uh, something malevolent toward them. Of course, you have your kids who uh, uh, severe school refusal, for instance, or separation anxiety. When it's time to leave the house, they're not always the ones sitting there quaking in the corner. They're out there, kicking and screaming, being very clear they don't want to go. OCD, sometimes you block their rituals and and some of these kids, they can get quite volatile. And finally, in the context of developmental disorders, so IDD, kids on the spectrum, kids with even with milder forms of communication disorders because they have difficulties expressing their needs or processing auditory information about what people are trying to get across to them, and so they overreact to at times, and because they're the otherwise typical coping mechanisms are compromised in many developmental problems. So I tried to formalize this years ago as sort of a scheme here. I'm not going to, inflict the whole thing on you. Um, but for today, just to make the point that really most of the action, and I mean, numerically in terms of, prevalence, it's really in this range here, where you have this alloy between impaired impulse control, a la ADHD, disinhibited, overactive, not so great in the problem solving and executive functions, combined with some type of mood disturbance that we really haven't got, believe it or not, characterizing that type of negative emotional reactivity has proved to be a little more problematic. But in any case, we'll, for now, just say that it's some kind of affective disturbance of high irritability, sometimes dysphoria, uh, sensitivity to threat, as I mentioned, or even manic symptoms. And these feed into it, if what's the underlying diagnosis, ADHD. We know that these folks are also prone to having oppositional defiant disorder and conduct disorder. And even what you probably heard of more recent vintage, um, dysphoric mood dysregulation, I'm sorry, disruptive mood dysregulation disorder, DMDD, I can't get it straight, but in any case, technically a mood disorder, but as a practical matter, really represents the high end of kids with oppositional defiant disorder. And then these things combine, and then you get aggressive behavior. Um, I just noted here what we talked about before. The kids, very few, certainly pre-adolescence, very few, but with these sort of callous unemotional traits, yeah, that can also feed in its own way. So here's your hot-headed, and here's your, so to speak, cold-hearted. Anyway, you don't have to take my word for it. We looked at, we had a large collaborative care child psych and pediatrics project. And so these are data from about 5,000 kids where we looked at rating scales of aggressive behavior, this one here, the overt aggression scale. We had an empirical threshold for what was significant aggression, and we used the sort of just about clinical threshold for an ADHD rating scale. And as you could see, given aggression, that's what this notation means. Given aggression, how many have ADHD? Well, almost 80%. Look at it the other way. Given ADHD, how many also have significant aggressive behavior? 42%. Looking at similar normed measure of emotional lability, much the same. Given aggression, 67%. You also have high emotional lability. And given emotional lability, it's a somewhat smaller proportion of those who actually have aggressive behavior. And if we put it all together, and here's everybody who has aggression, it kind of supports the idea that for the most part, it's some combination of this emotional lability, this emotional high negative reactivity with ADHD symptoms. It's only a small group here, 18% of this cohort who are reported to have aggressive behavior without elevations in either ADHD or emotional lability. Interestingly, likewise, if we look at so-called internalizing behaviors, this is depression and anxiety. Given aggression, there's a significant prevalence of elevated scores on anxiety and depression of 43%, but going in the other direction, if you have aggression without ADHD, it's really only 8%. All right, so what have we talked about so far? We focused on how psychopathology can contribute to certain forms of aggressive behavior. In kids, seen most often, though not exclusively, some alloy combination of poor impulse control and emotional dysregulation. So from a treatment standpoint, it seems reasonable that one should treat the primary underlying disorder to determine if aggressive behavior remits. So numerous guidelines keep saying the same thing. Focus initial treatment on the underlying disorder with valid pharmacotherapy and behavioral treatments if they exist. If not entirely successful, consider adjunctive medications. And so, as we'll be talking about soon, your second generation antipsychotics, alpha-2 agonists like guanfacine and clonidine, anti-epileptic drugs such as valproate, maybe some antidepressants in some circumstances. We'll talk about the data there. Ramp up the intensity of psychosocial treatment if possible and indicated. And if you have to have recourse to, say, the, risperidones or the arapiprazoles, to try to get a handle on these things, try not to use them for longer than absolutely necessary. But what happens in actual practice? So, in reality, kids might get initial treatment with stimulant medication, but good behavior therapy is inconsistently available. Then, after usually an inadequate trial of stimulant, I'm talking about trial psychiatric practice, uh, setting aside even primary care for the moment. Well, then, folks, we start adding risperidone, aripiprazole, quetiapine, the alpha agonist, guanfacine and clonidine, maybe our so-called mood stabilizers, divalproic sodium or lithium, antidepressants, trazodone, whatever, on and on and on. And before you know it, so many kids end up on 3, 4 plus medications. And so why does practice not quite sync up so well with um, guidelines? Is that, well, first of all, it's not exactly clear what's an adequate trial of first line treatment of, a stimulant. So you get to say, well, uh, you have an 8-year-old and he's on 27 of Concerta. Maybe the ADHD is a bit better, but you still have the aggression. Well, is that considered an inadequate trial? Should we carry on to 36 and beyond, or do we say, oh my goodness, we have to do something about this aggressive behavior? It's so-called refractory to stimulant treatment. So that's still an area of uncertainty. Uh, have we had any comparative trials of how these things stack up? Yeah, not really. I tried, as we'll talk about, they're difficult studies to do, but it does make it difficult when you're trying to pick the next agent. And in any case, the vast majority of all the data in this area, it's uh, principally on these things by themselves and seldom in combination in a cohort of kids who have clinically significant aggressive behavior. And when we turn to some of the data, I'll elaborate on that. So the net effect has been only intermittent industry interest in trials. Um, it's become a little bit of a third rail, the treatment of aggression, and this has been going on, for years. The FDA's been a bit skittish about getting into that area on the theory that, well, kids who are aggressive, that maybe they're more psychosocially disadvantaged, and if you went to a lousy school, wouldn't you also um, um, be frustrated and volatile and so forth? So there are all these sociocultural issues that the FDA is trying to stay away from, as well as the basic idea of, well, shouldn't you just be treating the primary disorder? And yet remaining silent on what you do about aggressive behavior that is refractory to treatment for that primary disorder. The FDA is really for decades now actually stay out of that tried to stay out of that business. So anyway, that's all to say that industry, has underinvested in trials with a couple of exceptions. Um, Clinical practice in psychiatry retains a somewhat improvisational character where, adding bits of, especially among inpatients, before you know it, kids are on 3, 4, sometimes five medicines. for this phenotype, including most concernedly because of their side effects, long-term use of second-generation antipsychotics, kids who don't have psychosis. And practically no de-prescribing trials for kids. In other words, you've been on this stuff for a while, things are better, well, maybe you don't need it anymore. There's sort of clinical inertia sets in. If anybody wants more details on this, we have a child psychiatrist named Jeff Newcorn and we have a chapter in a recent textbook of child and adolescent psychopharmacology. And you can email me for that. I'm happy to send or it's published now actually, so I can send you the actual reprint. So let's talk a little bit about specific medications. So number one, stimulants. Stimulants in ADHD are helpful. Well, duh. However, most studies are in ADHD where the aggression is an incidental outcome. So what do I mean by that? Well, you go out and you recruit all sorts of kids with ADHD, and then you might do a sub-analysis to see, well, did their aggressive behavior improve or not? But that cohort may not be representative of kids who come in with aggressive behavior as a chief complaint. So you run the risk there, if you haven't done a study where you're looking specifically for kids with aggressive behavior, maybe it's not so easy to generalize from everybody with ADHD to those who have demonstrably very high aggressive behavior. In kids who are on the spectrum, efficacy is a bit less certain. As you know, they're more likely to not tolerate the stuff as well, since it can exacerbate their hyperacusis or sensitivities to sound in particular. Stereotypies, can make those worse. But given the alternatives, usually warrants a trial, even if you want to start at a much lower dose and titrate slowly when ADHD symptoms are present. So I recommend just giving it a whirl, but going more gingerly. Similar situation in Tourette's. A substantial subgroup are highly impaired by brittle frustration tolerance, lability, ADHD. I've certainly seen kids where the tics are almost the least of their problems. One time we said, no, tics, that's a hard contraindication. You don't go there. But nowadays, we're much more willing to try stimulant treatment given the high impairment and the fact that exacerbation or onset of tics, it's not as big an issue as we had once suspected. Antipsychotics. Well, we're going to have share some data on that, but for now we'll just say that of all of them, risperidone still has the largest evidence and effect size for aggressive behavior among non-psychotic youth. Followed by aripiprazole had some positive trials for not only in the context of autism, but in the context of explosiveness for Tourette's. Both of those are labeled for irritability and autism. On the other hand, there was a negative trial for lurasidone. And there was an open trial published within the last couple of years of cariprazine. I know someone wrote in with a question about Vraylar. So cariprazine, it just showed it was sort of well tolerated, but at the end of the day, it wasn't that effective. And as you know, what are the downsides to these treatments? High weight gain, metabolic adverse effects, diabetes, hyperlipidemia, also repeatedly shown for SGAs. Even the ones that were supposedly more weight neutral, like aripiprazole in kids, some kids are still just going to balloon up. And even the risk of extrapyramidal symptoms is higher in kids than in adults, and we have to watch out in particular for withdrawal dyskinesias. Common, but usually transient, often more upsetting to the parents than to the kids. And the clinicians, no one likes to see that, but it does go away. Anticonvulsants, on the strength that several studies showed therapeutic potential among violent adults. We've looked at some agents as monotherapy. Small trials of valproate for irritable labile adolescents showed some benefit. There were some open trials in bipolar disorder that showed reductions in aggressive behavior, mixed evidence for efficacy in autism spectrum, and of course, although there's the most data involving valproate, of course, you wouldn't give it to anybody who's near childbearing potential, and even beyond that, the risk for PCOS and synonym functional ovarian hyperandrogenism, just diminished use with females in general. The guanfacines and the clonidines of the world. Fortunately, now we do have long-acting preparations of both clonidine and guanfacine. Even before they had the long-acting versions, there's a long history of their use with behaviorally dysregulated and aggressive kids. There was one controlled trial showed a modest effect when added on to stimulant, but to my mind, because of the potential to serve as a viable alternative to second generation antipsychotics in this context, we really should have comparative trials that are looking at that. But for various reasons, the stars are not in alignment to get any kind of treatment like that or study like that underway anytime soon. Oh, and here's just sort of my one-off comment here about clonidine versus guanfacine. Bear in mind that clonidine is by far the more potent antihypertensive, and that's because of its affinity for imidazoline receptors in the brainstem. It really quite apart from the supposed mechanism of action in treating ADHD, which is, noradrenergic effect in the front part of the brain. Guanfacine is much more specific to adrenergic receptors. So that's my 2 cents for given a choice. Unless you really want to sedate somebody, or maybe you're trying to treat hypertension too at the same time. I suppose maybe there's some justification, but in general, prefer guanfacine. Oh, something new I'll just mention quickly. There's a recent trial showing some benefit for a relatively high dose vitamin mineral preparations on irritability. Clinician global ratings improved more than placebo, but not parent report. Just keep an eye on that space. Maybe they'll come across a more parsimonious concoction that might have some benefit in this context. So, I want to turn a little bit to really what's the meat of the matter here, because to to the extent that so many of these kids have the underlying impulse control problems and ADHD, it makes sense to first try to optimize their treatment, and then if that doesn't work out, well, then what is the added benefit of second generation antipsychotic or a mood stabilizer and so forth. So this is what preoccupied me, for some years in a couple of trials that we had done, where I perceived a need to look at these treatment regimens and algorithms in a more that better models the way that treatment is undertaken in the community, which is to say, I mean, you might want to do a trial where you have aggressive kids and you give them, Risperdal or whatever, but that's not the way it should play out, given that the majority of those kids also happen to have ADHD. So even though the prevailing wisdom was, you try to treat the ADHD first, and then if there's still a lot of residual behavior problems, aggression, and so on, well, then you can add such and such. There really hadn't been studies that had done that before. So that was my goal. So the first order of business was to find kids who had ADHD, a disruptive disorder, high aggressive behavior. They'd already been on stimulant treatment at a certain threshold. Why? Because I wanted to find the kids who did not have such a robust response so that we could see what happens when we implement these add-on or adjunctive treatments. So no one of my trials was stimulant naive. So what was our initial protocol? Open treatment. We saw them weekly. We gave them the meds too. We usually started with, this is Concerta, Oros methylphenidate, adjusted weekly up to, admittedly, a relatively high dose, 90 milligrams a day if needed and tolerated. We switched them to Adderall as needed, and we go up to 35 a day. If those long-acting products interfered with sleep or appetite and so forth, we would use a shorter-acting methylphenidate product. I think it was, in those days, it was Metadate CD. And the main outcome was aggressive behavior. So if kids remitted, well, all right, well, fine. You're better, we're happy, we're done, discontinued from the trial. But if not, then maintain their stimulant treatment and then add. In our first trial, it was valproate versus placebo. And in our second trial, it was valproate, Risperdal, or placebo. And then we also had a blinded crossover for the non-responders. Anyway, so what was the outcome in our first study? So this is scores on our aggression measure. The blue dotted line indicates remission. And this is everybody a baseline. These are the ones who ended up being randomized to divalproex. These are the ones who were randomized to placebo. And these were the ones who weren't randomized because they had such a magnificent stimulant response. What's the point giving them more medicine? They're all better. So this is at baseline. Yeah, pretty similar. But look here. At the large group of kids, and it turned out to be just over 50% experienced remission just from doing the stimulant treatment in the methodical way that we did it, where we saw them weekly, adjusted the dose, it was measurement-based care. On the other hand, those who were did not have such a robust response and were then randomized to um, Depakote, you could see that 50% experienced remission, whereas only 10% of those who ended up on placebo. And the difficult levels. I mean, we really weren't titrating, the way that you would do in, an epilepsy or bipolar. And it turns out we didn't have to get to tremendously high levels, blood levels. So we did much the same, except this time, in our second trial, we randomized kids to, as I mentioned, risperidone, divalproex, or placebo. And here, now, even though we tried to tighten up the entry criteria so that we would get more kids who were not such robust stimulant responders, we ended up with a 65% of kids who were already treated with stimulant who came into our trial. And when we did the titration, offered some basic family therapy, we had an unexpectedly high rate of remission. This is what that group looked like, okay? Compared to those who did not have that benefit, and we were then able to randomize. Well, here's placebo, not so great. And in our trial, and admittedly, the numbers are small because we had so many stimulant responders. Numerically, it was pretty much a tie between the risperidone and the valproate. But the take-home message here is even those who had a reasonable response over an 8-week trial did not get anywhere near the level of improvement that our good stimulant responders had. I'll mention that weight gain in the risperidone group. This is only an 8-week trial. Kids put on, about 5 pounds on risperidone and only, substantially less than that on the Depakote. Here's the case. In the interest of time, I'm going to save the time for your questions at the end. I want to say a little bit about psychosocial treatments. Rather than go through each and every one of the various packages that are out there, I just want to increase your awareness of roughly what these most of them have more in common than they have than the ways in which they differ. And they usually fall out by seeking to affect aggressive behavior by one of 3 ways. By making that behavior irrelevant, ineffective, or inefficient. The underlying idea in this framework is that behavior serves a purpose. It serves a function. This is all part and parcel of functional behavioral assessment, which you might have heard of. So when we talk about making, in this case, aggression irrelevant, well, we change the antecedents. We change the context in which that behavior arose. So how do we do that? Modify demands and ways of communicating them. Sometimes, kids are set off by uh, parents who, basically yell at them constantly. I'm gonna hang up on that. Avoid the problem situation, at least in the short term. Provide attention before the negative attention-seeking behavior. So you are doing such a great job, I would really like if you could take out the garden. Just changing the context, even if only a little bit, can actually be quite effective. When we talk about making aggressive behavior ineffective, well, that's by changing the consequences. So whatever the payoff was, if you change the consequences, then you could say that the behavior is no longer effective in getting those consequences. So behavior does not reap the positive outcomes. you incentivize alternatives. So this is kind of garden variety point system um, type of intervention, token economy sometimes. If sometimes kids will, if they're upset, they'll try to retaliate at you by getting you mad. So do what you have to do so that the adults in the room do not get riled. And finally, negative consequences for the problem behavior. When we talk about making aggressive behavior inefficient, what do we mean by that? Well, if there's a more efficient way of fulfilling the same need, meaning it's overall less tumultuous, easier to do, well, then wouldn't you do that? So if you have alternative behaviors to fulfill the same need, well, what fits that bill? So this is where we talk about skills training, improved communication of needs. So the youngster gets frustrated in class and um, by the work and starts to get agitated. If the goal is to get out of that situation and therefore not have to cope with the academic demands, well, sometimes we'll have those kids, we'll give them like a little paddle or something that they can raise to get attention immediately, to help them refocus and get the work done and stay calm even though they're getting a little frustrated. Involvement in positive activities that emphasize their strengths, alternatives such as chill out time and so forth. So it's worth keeping these things in mind, that this is roughly the broad spectrum of how psychosocial treatments work. Some novel approaches that I'll just mention briefly, some interest on to the extent that there's some evidence that highly irritable kids overreact neurally. Their amygdala gets hyperactivated when they look at angry faces. Well, could we have a treatment where they're exposed to the angry faces, but somehow we do things that are all in kind of quelling their reactivity to that. Um, Exposure-based approaches, so just like we would treat a lot of anxiety disorders with a graduated approach to approaching what makes you anxious, you have an hierarchy there. Much the same here. So we start off with um, giving a direction that will be there's a high probability of following, and then you move up to one that has a somewhat lower probability, and you lavishly reinforce the compliance and so forth. And those types of approaches are being investigated now. Okay, so to summarize, aggressive behavior is a common complication of numerous psychiatric disorders in youth as well as adults. The basic principle remains to treat first the underlying disorder, and in the preponderance of cases where impulse control difficulties are present, stimulant treatment requires methodical titration to either maximum dose, best tolerated dose, or um, before you move on to adding meds for residual aggression. That was really the take-home point for the studies that I had done, that when stimulant treatment is implemented in a measurement-based care with following a rigorous algorithm for finding the right agent and the right dose, you end up with remarkably high rates of not just reductions, but actually remission of aggression. We have limited data for risperidone and valproate as adjuncts. There's some data possibly for citalopram. In the interest of time, I didn't go into that study. But the fact is that a need remains to evaluate these polytherapies in high quality trials and especially that compare active treatments. So, we did the one where we tried to compare risperidone and valproate, but there's a huge need, I think, to to do a large trial of comparing, say, adjunctive intuitive, guanfacine versus Risperdal, for instance. That would be a major contribution. We also need de-challenge studies or de-prescribing studies to figure out, well, how long do you really need to be on this stuff? Stimulants, I think we know most kids throughout the school years at least are going to need something for that. But in terms of these adjuncts, we really don't know for how long you have to be treated with them. So important to get psychoeducation and behavioral strategies, calm down family life. These problems can be so interpersonally corrosive. If you folks in primary care, whatever you got to do to at least encourage people to some degree, find some time to enjoy each other's company. That's so important, and we overlook it a lot of the time. Environmental modification should be first line in developmental disorders. What I was saying before about some of the changing the antecedents and stimuli. The schools, in theory, are supposed to have somebody who specializes in this. It's kind of at the core of ABA, applied behavioral analysis, and its variants in the context of developmental problems. And when you have to, you have to. Low dose antipsychotics in severe or refractory situations. So with that, Kafik, should I turn over
Yeah.
some of these questions?
Yes, we can
All
dive
right.
right into questions. Thank
All
you for
right.
such an informative talk and sharing your research. Um, let's
So I'll just rumble right into them.
Okay, thank you.
Someone asked, in terms of helping teen girls with ADD and emotional dysregulation, how do you help with increasing awareness to work on learning aspects of social executive function? So when it's less impulse control, but more issues with lack of self-awareness, how to help parents and what resources to give them. In this kind of situation, I think it's a great question, by the way. You want to differentiate between what's, as we say, a skills deficit from a performance deficit. Are we really talking about someone who they really just don't know kind of the very basics about? You ask, you say something to somebody, you wait for them to answer very basic social skills. Someone who is super quick to assume the worst, and somebody is not looking at you at all, but you think they're blowing you off or whatever. These folks who really don't know how it works and need to learn what to do, or as is probably more often the case, is it a performance deficit? That means they know what to do. They know they could give great advice to somebody else who had, who was in the same situation, but when it comes time for them to do it themselves, well, it's not so much a matter of knowing what to do, but rather of knowing when to do it and to suppress competing behaviors. So this is why even when it looks like someone is completely clueless about how to act around people and take things too personally, or monopolizes the friend's time and gets jealous and that sort of thing, that kind of social immaturity, that whole spectrum of stuff. You still want to treat the ADHD. But then in addition to that, sometimes more structured activities pave the way for improved social interactions, developing patience with others. when they see that modeled, well, everybody else is waiting to have their go at whatever. Um, so, so that's the way that I, might approach that. Now, how do you determine if the aggression in an ADHD patient is related to the disease or to the medication? The medication is helping with focus, but causing aggression. Does it need to be changed, or should we add something for the medication? Wonderful question. To the question itself, the bottom line, I would almost always opt to change the medication rather than try to medicate a side effect. The type of, as I call it, affective toxicity that you're describing, it is a thing, where some kids are very sensitive to stimulant treatment, where it can make them more irritable. They kind of get tensed up and all the fun's gone out of them. These kids who could, never really cared much about schoolwork or being organized, but they're sitting there in the class and they see, now all of a sudden the vigilance is way too high. And she's using a number 3 pencil. We're supposed to be using number 2 pencils. That kind of intensity, uh, the irritability and so forth. That's, we see that pretty often actually. And the good news is that for the most part, it's dose dependent. Um, uh, well, I'll make this distinction between kids with developmental issues and the kids on ASD or even with Tourette's are a little more susceptible to this kind of AE and these types of adverse effects of the stimulant. But among everybody else, it tends to be dose related, and maybe you can back off on the dose and um, get some benefit, without exacerbating the irritability. Now, then again, you have to pay attention to what's the specific treatment. We have data showing that of all things, I'll just use the trade name, why not? Vyvanse is especially likely to produce this type of picture. I've presented that data. I'm trying to write up the manuscript now. When we started these studies, Vyvanse hadn't come out yet. When it did, I got so many kids referred to the study who were, yeah, they were on Vyvanse, but the aggression was through the roof. Well, guess what? We stopped the Vyvanse to switch them over to the medications that were formulated for the study, and they kind of went back to just being happy hyper. So we solved that problem. Um, Anybody on Vyvanse with that picture, please switch them to a methylphenidate product or even Adderall and see what happens. You might find it's really medication specific. The kids who really don't seem to tolerate the stuff very well at an effective dose, and this is in particular the kids on the spectrum, some kids with Tourette's. The other strategy is to use a non-stimulant, and I usually, an alpha 2 agonist rather than, viloxazine, something that's a little more on the chilling side, so to speak. And if you sort of get somewhere with the ADHD, but the residual symptoms are still there, then on occasion, a fair bit of the time actually, reintroducing stimulant under cover of, say, the guanfacine, or even in extreme cases, if you have to start risperidone because the behavior is so egregious and it's causing so much problem. The kids getting, it's about to be kicked out of school, the daycare, whatever. Sometimes if you re-challenge with stimulant under those conditions, then it's better tolerated and doesn't make the irritability and all that worse, and you do get better behavioral control. There's 1 minute left.
Let's do one more maybe.
Does ADHD incur high risk for developing depression or obsessive compulsive disorder? The short answer is depression, yes. OCD, maybe. Rates of depression are higher among those with ADHD. You could quibble about, well, is that a bit of an artifact because they both have irritability, while it's not an ADHD symptom per se, is elevated in this crew. So does it sort of mask as depression. But even setting that aside, yes, there is a higher vulnerability to the lifetime risk for developing depression, given ADHD. On the OCD side, most of the studies start with an OCD cohort and look at the prevalence of ADHD within that. When you go that way, yeah, you find actually quite high rates of ADHD, but there haven't been very many studies, believe it or not, that start with ADHD and then look at the prevalence of OCD. Regardless, my message, of course, I'm a little biased here coming from the ADHD world. I would say you got to treat the ADHD first. Because, well, number one, you're going to have to treat it eventually anyway. Secondly, you're going to get your answer if you're on the right track way before you're going to see what, get the verdict on whether the trial of an SSRI, for instance, is of any use. And most importantly, if you treat the ADHD effectively, so many of these kids now become candidates for behavior therapy, for CBT in the case of depression, or in the case of of OCD, you can do the behavioral treatments, the exposure and the response prevention. Remember, you have to have a certain amount of frustration tolerance, attention, persistence, and so forth in order to undertake and profit from these other treatments. Same for trauma. I've tried doing trauma-focused CBT with kids who can't, kids who can't sit still, or adolescents who really can't focus. Well, what's the point? Treat the ADHD first. Believe it or not, so much of the time, now you have somebody who can benefit from these other treatments. So that's my commercial for, there's always going to be exceptions, but I say treat the ADHD first, or if you have to get both underway, bearing in mind that someone's really depressed and you want to get fluoxetine trial or something underway. Sure, get that started, but not at the expense of deferring treatment for the ADHD. And here's my email. I'd love to take any queries from anybody here today. Just please write me.
All right, thank you so much. So we've reached 1 o'clock, so we'll bring the session to a close. The University of Iowa Carver College of Medicine is jointly accredited to provide continuing education for physicians, nurses, social workers, and physician associates. All other participants will receive a certificate of participation. Attendees are eligible to claim continuing education credit by completing the evaluation and downloading their certificate of participation. So instructions on how to claim credit, I uploaded into the chat, and I'll also send in the follow-up email. If you have questions, please feel free to reach out to me at Kafi, Kafi-Dixon, Dixon at uiowa.edu. So in closing, I just want to thank Dr. Blader for presenting today and sharing this information with Iowa providers. And thank you all for attending. Have a great afternoon.
All right. Thanks so much.
Thank you.